I'll just wait for one moment here. Yeah, there we go. Hello, everyone. Hopefully, everyone can see me and hear me okay. I've got a special guest here with me. Good afternoon, all, and welcome to our Lupus Spotlight on Immunizations, a virtual symposium presented by More Than Lupus. My name is Kelly, and I am a 30 plus year systemic lupus patient and the creator and executive director of the Portland based nonprofit More Than Lupus. And if you are unfamiliar with More Than Lupus, we are a patient centered, inclusive place for lupus patients to get connected to community, to find patient resources, support, and advocacy information. Now, before Dr. Thomas introduces himself, I wanted to give a disclaimer for today's discussion. And here it is. So please understand that the opinions shared today are purely for informational purposes and do not replace the medical advice and or opinions of your doctors or healthcare professionals. Dr. Thomas is a qualified professional whose comments are based on years of education and medical experience in the field of rheumatology. However, he is not liable for his comments since he is not acting as your personal physician and does not know the nuances of your medical history. Lastly, if you are experiencing lupus or lupus overlap symptoms, overlap diseases, it is important to follow up with your doctor to seek the treatment that is best for you. So please welcome, without further ado, Dr. Don Thomas Jr.
Oh, thank you, Kelly. Thanks for having me here today.
Dr. T, tell us a little bit about yourself. I know many people know you from us collaborating on different events and from reading your book, obviously, the Lupus Encyclopedia. Can you tell us a little bit about your background and why you love talking about this topic in particular?
Sure, Kelly. Just briefly, and when I was an intern in the early 1990s, one of my very first patients to take care of was this young woman on the internal medicine ward at Brooke Army Medical Center. Just a beautiful young woman, very pleasant. She had severe lupus nephritis, treated with the best medicines of the day, high-dose steroids and cyclophosphamide. And she was very Cushingoid, which means she gained a lot of weight from the prednisone. She showed me her picture. I'll never forget it. She just looked like a beautiful homecoming queen. And here she was just completely changed within just 6 months of treatment. And her lupus nephritis was not responding. And immediately, number one, I was intellectually spurred, why would someone's immune system attack their own body? But number two, more importantly, how can we better help people get better and learn how to take better care of themselves? And it wasn't her fault at all. It was just the poor treatments of the day. Unfortunately, she's probably not here anymore, but I've made it my goal throughout my career to help people learn the best ways to take care of themselves with the best that we have available so that people can live longer and better lives. Because most people, and to include doctors, don't know all the right things to do with lupus. It's not just about taking medications. There are so many other important things to extend one's lifespan and have a good quality of life. And so today's topic is near and dear to my heart because infections are the second most common cause of death in lupus patients, and the vast majority are preventable. So thanks for having me today about this important topic.
Thank you for sharing that background. So I just think we should get right into it and maybe start at the beginning with the basics. So what are immunizations and how do they work?
Sure. So immunizations are a way that we ask people's immune system to recognize different germs and learn how to be able to attack against them. For example, if you get infected with the pneumococcal bacteria, which causes pneumococcal pneumonia, if you've never been exposed to it before, your immune system doesn't know how to respond to it very well. Well, we have two different parts of our immune system. We have something called the innate immune system, which is the primitive immune system that responds to everything in the same way. And we have the adaptive immune system, which is the modern part of our immune system that learns to recognize things, keep it in a memory inside of our immune system, and is in a more advanced way to respond. So if you get infected with a new pathogen or virus or germ like pneumococcus or COVID-19 and your immune system has never been exposed to it before, you have the innate and primitive immune system responding to it that gives us the fevers and the weight loss and the feeling horrible, the fatigue, and even potentially death. But we need more than that. We need the adaptive immune system. So giving a vaccine basically gives some part of the vaccine or some type of signal to instruct and teach that person's immune system to learn how to recognize that particular germ, so that in the future, when they actually become infected with the germ, they'll have a much better, robust immune response and protect that person and greatly decrease their risk of getting sick and, most importantly, from dying.
Mm-hmm. And as you mentioned, infection viruses are the second leading cause of death with lupus. So, kind of to dovetail on what you said earlier, why are immunizations necessary for people with lupus to consider?
Yeah, they're very necessary because of that number one fact about how high of a death rate we have. In fact, if you go even back before we had any medicines for systemic lupus, let's say back in the 1930s and 1940s, before prednisone was even around, back then, infections were the biggest cause of death in patients, even along with the lupus disease itself. And so we know that the abnormal immune system of lupus increases the risk of infections in the first place because their immune system is not able to fight against infections as well as it should. And then this is backed up by more modern studies. For example, in 2014, the Netherlands, they published a really nice paper. The nice thing about a lot of European countries is that they have a socialized medicine system. And this gives them just an incredible amount of data where they can do research for the entire country and not just little pockets like we do here in the United States. And what they showed is that patients with systemic lupus were 13 times more likely to develop severe invasive pneumococcal pneumonia compared to the general population. They were able to look at all the data of the entire country. Now, one may say, well, lupus patients are immunosuppressed. They're on prednisone, they're on azathioprine, they're on mycophenolate. And that's true, that does increase the risk of infections. But what they showed is that even those patients who were not immunosuppressed, even those who were only taking hydroxychloroquine or Plaquenil, had a significantly higher rate of pneumococcal pneumonia. And so the authors concluded that every lupus patient, no matter what medicines they're on, should be vaccinated against pneumococcus, which is one of the most common causes of infectious deaths in our patients.
Interesting. And not to mention how lupus can already compromise the lungs, and then you add a type of respiratory infection.
And not only that, but just think of shingles, for example. There was a study presented at the European Union League Against Rheumatism just a few years ago. It just presented some fascinating data where they showed the incidence of developing shingles in different age groups. And first they showed how often it occurred in healthy people. And they showed it decade by decade. And then at the 70th decade, so people in their 60s, it showed that the incidence of developing shingles was 8 people per 1,000 within a year. And the Centers for Disease Control decided that that's the magic cutoff, where it's cost effective to have people get the shingles vaccine to prevent that from happening. Then they looked at this data in multiple different autoimmune diseases to include lupus. And out of all of them, lupus had the highest rates of shingles than any other group, to include 20-year-olds. In fact, in the 20-year-olds, it was like 20 some people, 28, I believe it was, for every 1,000 people within a year, compared to just 8 in an old, healthy person. That's how much more it is. And one may think again, well, these are immunosuppressed patients, they're taking steroids and so forth. But then let's look at the column that they showed for rheumatoid arthritis. The big difference between rheumatoid arthritis, which is also an autoimmune disease, and lupus, is that almost every person who has rheumatoid arthritis is treated with an immunosuppressant. Very few people with rheumatoid are treated with just hydroxychloroquine or Plaquenil. They're almost all on TNF inhibitors like Humira, for example. So they're much more immunosuppressed than lupus patients, but they had much lower rates of shingles compared to lupus patients, where about a third of our patients are not on any immunosuppressants. They're only on hydroxychloroquine. So it's the disease itself that increases the risk. And shingles is horrible, by the way. When people get shingles, it's an incredibly painful disease. Many patients describe it to me as taking a hot iron and putting it on your skin. And just imagine how horrible that is. And it's an unrelenting pain that just does not go away. I've had grown men in tears who, in fact, one of my favorite rheumatoid patients who kept resisting the shingles vaccine, he came in with it all down his leg and he was just crying in pain. And he just kept saying, Dr. Thomas, I wish I would have got my shingles shot. Another patient of mine who the shingles, it attacked the nerves that go to the muscles of her arm, and she has a completely paralyzed arm to this day. And she's the same way. She just, every time I see her, she cries and she says she wishes she would have got her shingles shot. People who are fans of Justin Bieber, you know that he has a paralyzed face now from shingles, and he's not even immunosuppressed. And these are completely avoidable. That's why when I turned 50 years old, I ran to my pharmacy to get my shingles shot. You know, it's us doctors, we see all these horrible things that tell us why we need to get these things. And I just wish people could see things through our eyes instead of seeing all the things on the internet that makes them scared of getting vaccines, because the disease is so much worse.
Right, and that's something we're going to talk about in a little bit. I want to go back, though. I don't want to get too into the weeds, but this was really fascinating what you just mentioned about the shingle rates being so high in lupus patients. Is there a theory on that? Could that possibly be related to those high levels of interferon 1 or some other type of immune disease mechanism within lupus?
Yeah, I don't think we know exactly why. We just do know that with lupus, the entire immune system is abnormal. It's not just one part of it. And that's one reason, by the way, why it's so difficult to find therapies for lupus. In fact, it's probably not just one disease. It's most likely multiple diseases that we just lump into this term called lupus. I mean, if I lined up 1,000 of my patients, none of them would look the same. You know, why does this lupus patient get recurrent blood clots and rash? This patient gets arthritis and inflammation of the kidneys, while this patient over here gets recurrent strokes and mouth sores. I mean, these are definitely different diseases, and it causes abnormalities of different parts of the immune system. And when that occurs, they can't fight off infections as well as they should. And so it's not just as simple as saying high interferon rates, because that's just some of our patients.
Really fascinating. Well, I think moving into the next question, we've already talked about the pneumococcal, we've talked about shingles, but which immunizations are, in your opinion, the most important for people with lupus, obviously, besides those two?
Well, my answer today would be very different than 3 years ago, of course. In my clinic and in my professional life, I have unfortunately seen numerous people die from COVID-19. I've seen families devastated from family members killed by COVID-19. And I have never seen this with any infection in my entire career. Prior to 3 years ago, I would have said influenza shots, because the flu killed around up to 50,000 Americans every single year. boy, that just seems like a dwarfed number today, with now over 1 million Americans dead from COVID-19, and many of them I know personally. So today, absolutely, the COVID-19 vaccinations and double protection with Evusheld, which we'll talk about in just a little bit, that's the most important one, because it's just deadly. And then number two, I would say pneumococcal vaccinations and influenza vaccines next. I would say Shingrix shots for shingles is right up there. And then one that's oftentimes overlooked, Kelly, is Gardasil vaccine. People with systemic lupus, when we look at our newly diagnosed patients, have a much higher rate of infections with human papillomavirus, HPV, which Gardasil is given to prevent that. The bad thing about HPV infection or human papillomavirus is that it's the number one cause of cervical cancer, which is one of the most deadly cancers throughout the entire world for women. But in addition, when we look at our lupus patients, they are at much higher risk for a lot of cancers. And when you look at that list of cancers, which I think is now like 11, that they're at higher risk of getting than the general population, several of those are HPV-associated cancers. And so we have to look at Gardasil as a cancer preventative therapy for our patients as well.
Really interesting. That's something that is not talked about enough, and also the estrogen-driven cancers as well with lupus too. Another thing, I know this isn't something that we discussed talking about, but the Epstein-Barr virus, I've read some things about them developing a potential vaccine that could prevent EBV. And, as you've talked about, and we've talked about here, EBV is one of the top viruses in lupus causation. Have you had an opportunity to read much on that?
No, right now it's theoretical. When we think about the causes of lupus, and you look at all the different studies, the number one thing that has the most evidence behind it is Epstein-Barr virus infection, because Epstein-Barr virus, the virus itself infects two cells in the body. One is the epithelial cells, and two are B cells. B cells are those cells that make that anti-nuclear antibody, that make that anti-double-stranded DNA antibody, the anti-Smith antibody that, most people, almost everyone watching this is positive for. And our patients with systemic lupus have much higher rates of Epstein-Barr virus infection and the viral loads that come along with it. So there does seem to be some significant connection. So a big question is, if we could possibly vaccinate people who are at high risk of systemic lupus, in other words, people who come from families that have autoimmune disease in it, could we possibly decrease the onset of systemic lupus in people? And it's theoretical, but it's definitely a possibility. So it's very exciting if we can get a vaccine that works. So far, the vaccines that have been studied have not had very good results, though. But now with the modern techniques with mRNA vaccines, like with COVID, there is that chance that we might be able to get something useful in the future.
We can only hope for that. I know, personally speaking, Epstein-Barr virus was my lupus catalyst at 11 years old. So can't imagine the trajectory if for a child who may be able to take a vaccine, who has family history of systemic lupus and maybe is more inclined to potentially developing it, to sidestep something like that would be a tremendous medical breakthrough. Let's see here. Okay, let's go back and talk a little bit more about COVID. So the new COVID vaccine recommendations for people with compromised immune systems. Most of us have had 4, but now they're saying that a 5th shot can be used for those that are approved by their doctors for being immunocompromised. So do you mind talking a little bit about why that is and what you recommend for your patients? And then we can kind of go in and talk a little bit about Evusheld. I had to think before I say it.
Sure, yeah. So just this, I believe it was in June, the Centers for Disease Control included in their guidelines that they recommended that people with a moderate to severely immunocompromised conditions should consider getting a fifth COVID vaccine if they started off with Moderna or with Pfizer. And this fifth vaccine should be given 4 months after let's see, yeah, 4 months after their fourth shot. If you started off with the J&J vaccination, then you should get a fourth vaccine, and so that's the difference with that. And again, it should be 4 months after your third vaccine in that case. And the reason for that is that they're seeing in the studies that our patients who have immunocompromising conditions appear to have waning of their antibody response sooner from their vaccines, but also there's certainly those who are at highest risk of having severe outcomes. You know, people hear about the Omicron variant and how it has not been nearly as deadly or infectious with people, and that so things have been relaxed around the world. We're unfortunately not seeing that in our systemic lupus patients who have compromised immune systems. We're seeing them get very sick. I had a patient pass away, unfortunately, 2 months ago from Omicron, right before I was getting her set up for Evusheld. Another patient of mine was got infected with Omicron. I was getting her set up for Evusheld, and a family member brought it into the house, and she ended up on a ventilator and almost died, but fortunately pulled through. So we cannot overemphasize how important these things are, because when I look at my patients over the last 2 years, I can clearly divide those up into those who were never vaccinated, those who have been vaccinated, and those who have been double armored with COVID vaccines and Evusheld both.
I'm so sorry about the loss of your patients, and I know you care so much about your patients' well-being, and I'm sure it's such a challenging time to be a physician in so many ways, and we appreciate you sharing that with us. You know, if I could kind of take my moderator hat off and put on my patient hat and share kind of some of the having my finger on the pulse of what patients are saying. A lot of what seems to be the hesitancy with regards to getting another vaccine and or obviously the prophylactic treatment with Evusheld is, okay, what am I going to have to do about my meds? Am I going to have to temporarily adjust them again? And what does that look like? And will that affect me? And am I going to have some sort of flare or setback from an additional vaccine and or a side effect from the prophylactic treatment with the Evusheld? So, you know, if I know I'm not your patient and you're not my physician, but hypothetically speaking, if I were to come to you with those concerns, what would some of the feedback be for you, generally speaking?
Sure. So first off, there's a great set of guidelines given up by the American College of Rheumatology. If you just simply Google American College of Rheumatology COVID guidelines, you'll easily find those recommendations online. Also, Kelly's going to post the link. We're going to have links for people with all these important sources as well. Just go to Table 3. On Table 3, it tells you exactly what to do with every single medicine you could be possibly taking. So for example, after taking immunosuppressants like methotrexate, azathioprine, mycophenolate, they do recommend stopping the immunosuppressant for 1 to 2 weeks after the vaccine. And that's because these particular vaccines, especially mycophenolate and methotrexate, have been shown to decrease the response rate. However, balancing that out is also not having a flare-up, because having a flare of systemic lupus is that's one of the worst things that could possibly happen to you. So if we have a patient who is at high risk of flaring, then in that particular patient, we would not recommend stopping the medications. Getting the vaccine and having a partial response is better than having no response or having them flare up. Someone who's at moderate risk of a flare or low risk of a flare, we might just stop it for 1 week. Someone who's at no risk of flaring or has been in remission a long time, I would easily stop it for 2 weeks. The biggest culprit out of all of our medications, though, is rituximab or Rituxan. I have checked antibody response levels in our patients to the vaccines in a lot of my patients, and the ones where I've seen zero response have always been my rituximab or Rituxan patients. And so it's really important to especially time your vaccines properly with that. If you've been in remission for quite a long time, you may want to consider seeing if you can stretch that rituximab treatment or Rituxan as far off as possible. For example, if you're getting it every 6 months and you've not had a flare in a year or two, consider seeing if you can go to maybe 10 months or 8 months and then getting your vaccine a month before. And that's when you want to get the vaccine, is about 4 weeks before your Rituxan treatment. But of course, unfortunately, some people have severe disease and get their Rituxan every 4 months. And if they even get a little late, they flare up in that patient. We're just kind of stuck with giving them their vaccine 4 weeks before the Rituxan, knowing that it's probably not going to have a good response. However, there was a study that came out from Austria, and they showed that with patients who had zero responses to the first two COVID vaccines, when they got the third one, 85% of those patients did have a response to the vaccine. So it's never, it's not 100% that it's not going to work. And then plus vaccines, by the way, this is really important too, Kelly, is that when we measure responses to vaccines, there's two different ways we can measure it. We can look at a large group of patients and see what percentage of them are hospitalized and die and end up in the intensive care unit compared to those who don't get vaccinated. But the other way is by checking these antibody levels. But when we give someone a vaccine, we're teaching the entire immune system how to respond to COVID-19. And it's not just the B cells that make the antibody, it's also the T cells. And we just don't have a way to measure how well the T cells are responding. So even though someone might not have a good antibody response, there's other parts of the immune system that we're still teaching how to respond. So it's a lot more complicated than just checking antibody levels. Right. Bottom line is it's complicated, and read the guidelines and then ask your physician.
Well said. And to be clear, the COVID vaccine isn't giving anyone COVID. They're teaching the immune system how to respond potentially to COVID, which seems to be a continued rhetoric out there that unfortunately is still kind of going around.
Yeah, there's zero particles from the COVID virus in the vaccine, zero. So it's 100% impossible to get infected with COVID from a COVID vaccine.
Mm-hmm. And as something that you had published not too long ago, it is the most studied vaccine in history. Is that still accurate information?
Oh, yeah. Mm-hmm. It's just amazing the amount of resources and money and world help amongst all the scientists and doctors and researchers into this one infection in such a small amount of time. And even before that, the mRNA vaccines were studied for 20 years, and the science was so greatly evolved by the time COVID-19 rolled around. That's why it was so easy to get those vaccines rolling out so quickly.
Yes. I think that is such a crucial piece of information for people to understand, that technology has been around for decades. So it wasn't something that was just invented overnight to get the vaccine rolling out quickly. Really important information. Well, I wanted to share real quickly that I have had 4 vaccines, and I am recently, obviously I've had COVID, and as you know, Dr. T, it's been pretty rough. Because I am on 4 immunosuppressant medications. And so I can't reiterate enough how important it is, if your physician has recommended you to get the COVID vaccine, to comply and do that. I wish I would have had a 5th vaccine in me. I wish I would have had the Evusheld in me as well, because it's very scary indeed to think about where I might have been if I hadn't had the 4 shots in me when I contracted this virus. It is not something to mess with, and not something to get complacent about. I cannot stress this enough, everyone who's watching this today. And to know how many patients are continuing to pass from this virus is very, very humbling and sad indeed. So that's just, I'm not going to go any further into that, just to say that I'm truly, truly thankful for the technology, and I am thankful that I had access to the healthcare to get those shots. And once I am cleared and able, I will be getting my 5th shot. And yeah.
And Evusheld.
Yes. Yes.
I'm glad you're recovering, Kelly. Thanks for sharing.
Thank you. Thank you. So, a lot of news coverage recently is actually kind of pivoted from COVID into this new monkeypox virus. And, in the lupus community, really haven't heard much about it in the patient community. I just was curious. I know this is kind of a bonus question, but what are your thoughts on this monkeypox outbreak and the potential vaccine and potential antiviral therapies?
Sure. So monkeypox, everybody's heard about it on the news. One thing I'd like everybody to keep in mind is that only 1% of the patients are female. And so I know the vast majority of your viewers right now are female, and I know there's a lot of apprehension because of what they've heard on the news, but you're already in a very low risk category. 94% of infected patients have been men who have sex with men. Why there's that gender difference, I don't know, because women have sex as much as men do. So we don't really know the reason behind that. But because of that, there's such a big shortage of monkeypox vaccines, or vaccines that are effective against it, that is now mainly being offered to the highest risk group, which are men who have sex with men. But the next group would be immunosuppressed patients. So once production is up, I will be recommending to my own patients that they do get vaccinated against monkeypox as soon as it's available here in the state of Maryland for that particular group, which I think will be the next group.
Interesting. So you have a timeline at all as to when that might happen?
Boy, I don't. I wish I did.
I know.
The technology, by the way, is different than the mRNA. So it's the mRNA vaccines were pretty easy to churn out, but I think it's more difficult with the pox vaccines.
Interesting. Well, thank you for a little update on that. I just was curious for myself, and I know that a few people had reached out about that, and whether or not that should be something that obviously affects part of our population, and we should all be concerned about caring for the population. So I appreciate you clarifying that, and we'll be waiting to hear more information as it's released. So I would like to turn to, now that we've a little less than a half an hour here, to turn to the comments, as people have been logging on.
Oh, can I talk about Evusheld real quick?
Oh, absolutely. I'm sorry. That's right. We did not get into that. Please do.
Yeah, so Evusheld, number one, most of you have probably not heard it on the news, and that's one of the biggest questions I get from my patients when I recommend Evusheld is, well, why haven't I heard it on the news? Because everything's on the news about COVID. Production was very, very difficult at first. For example, the state of Maryland, we only received 5,000 vaccines for the entire state when it first rolled out. And unfortunately, that's when my patient passed away with hers. I was trying to get her set up for Evusheld, and it was just so hard to get a hold of. But now Evusheld production is very up there. We're one of the treatment sites here in the state of Maryland because we have so many immunosuppressed patients. And by the way, if you're here in Maryland and you have trouble getting Evusheld, we're offering it to even people who are not patients of ours. So please feel free to give us a call. What it is very different than a vaccine. Think of it as being a double armor against COVID-19 when you get it along with the vaccine. It's a monoclonal antibody. And for those who, it's a big, long, fancy word for just an antibody that's directed towards COVID-19. So when someone gets infected with the COVID-19 virus, the antibody against COVID-19, which is Evusheld, latches onto it and prevents it from infecting the person. And Evusheld is actually 2 different monoclonal antibodies. This one shot into each buttock, both at the same time. They're both different. One of them is effective against the Omicron variant, which is good. And then it immediately gives you protection against COVID-19. I tell my patients when they walk out into the parking lot, they're going to be much more protected than when they walked in from the parking lot. The antibodies last for about 6 months before they start to wear off. And so the FDA now does approve getting it every 6 months, which we're recommending to our patients. Just to show you the effectiveness and safety. Just about 6 weeks ago in the New England Journal of Medicine, they published the phase 3 clinical trial results. They studied over 5,100 people. They monitored them for 6 months after the vaccine. So it was a very large study. And they gave some of them Evusheld, they gave some of them fake shots, which is called placebo. The ones who got Evusheld had an 82% reduction in infections compared to those who got placebo. In the study, there were 2 COVID-related deaths. There were 5 COVID-related intensive care unit admissions. Every single one of those, Kelly, was in the placebo group. The few people who got infected in the Evusheld group had mild symptoms, the vast majority of which were discomfort at the injection site, fatigue, and headache, but nothing like COVID vaccines. I give someone a COVID vaccine, I say, you're probably going to feel crappy the next few days, but that's not true with Evusheld whatsoever. I got it myself, and it was a piece of cake. Also, safety-wise, it was I already mentioned that, it's just 1% difference between placebo and the Evusheld. And so I do highly recommend people who have compromised immune systems get Evusheld. Now, who's immunocompromised? It's anyone who's on an immunosuppressant medicine. So it's really most of our lupus patients who should be considering to get it.
And it's 2 shots.
2 shots
in the tush, right? Yes.
One in each side. And by the way, if you have trouble figuring out where to get it in your area, I'm pretty active on social media, and it seems like there are a lot of doctors out there who don't know about Evusheld or what to recommend to their patients. If you go to my website, the Evusheld blog post article that I wrote, and Kelly's going to share that, there's actually a locator that you can click on, the Evusheld locator, and then you can put in your zip code, and it'll tell you exactly where in your area you can get it. Like if you put in your if you're in Silver Spring or Greenbelt, Maryland, and put in your zip code here, you'll get our office, for example. So it is easy to find places close to where you are.
And
and by the way, also, please don't go to somewhere that's going to charge you a lot of money. I've actually seen people on the internet, and I've had one patient where a hospital tried to charge them like hundreds of dollars. The government is giving this to us. We don't charge patients a cent. So I don't know what's going on there, but make sure you find, you're probably not going to a hospital injection site would be best. So please don't let someone try to charge you a bunch of money.
That's terrible. I haven't heard that. That's awful. Shame on people for doing that. Goodness.
I saw it on social media. I didn't believe it until a patient of mine came in and told me it happened to her. So.
Oh my gosh, that's just awful. I was thinking about what you mentioned that you said to your patients about how they can walk out of the doctor's office and be more protected than they were walking in instantly. And it's so... It's not very common for us to have a medication or a vaccine or something like that work so quickly. So I would imagine that would just really prompt people, particularly if people are trying to get back to normal life and maybe want to travel a little bit safely, to be able to have that as that extra security. Sign me up. I can't wait till once I'm safe with this COVID out of me, then I'm doing that.
Yeah, Kelly, that's actually one of the reasons I got it. Number one, it was to protect my patients. I have so many immunosuppressed patients. I protect myself. I protect my patients. Mm-hmm. But also, I'm going to start vacationing next week, and most people are not wearing masks on the plane or in the airport, and so I cannot trust, what's going on out there in society. I'm very conservative. I've never been infected, but I live in a shell. And that's partly to protect my patients, but that's why I got it also because of traveling.
Wow. Yeah, it's great that we have that now as an option. So check with your doctors and find out where you can get it, and read the blog by Dr. Thomas, and educate yourself on that because it's something that is available to you for most of us who are on immunosuppressant medications or have either primary or secondary immunodeficiency syndromes. Let's see here. Well, let's go to our comments. Now that we have about 20 minutes left, we have Cheryl joining us. Cheryl, where are you joining us from? Let us know. We've got Mari joining us from Chicago. Hi, Mari. Thank you so much for being here. We've got Tamara joining from Georgia. We've got all sides of the U.S. here with us today. And Mari says, Dr. T and Kelly, thank you so much for this. You both look beautiful and handsome this Sunday afternoon.
Mari's one of my favorite people now. Thank you, Mari.
Although I think you're in Chicago and not in Japan, so it is still technically Saturday, not Sunday, but yeah, that's okay.
She says it's funny she says that because I thought it was Sunday too. Because yesterday I had to take a loved one to a medical procedure and I thought it was Saturday yesterday.
Oh my gosh. Well, with my COVID brain, I don't know what's going on half the time. So, we've got someone joining us from Ireland. Wow. We've got Stephanie McGrary here. We love having people join us from all around the world here. And I find it really fascinating, too, to hear perspectives on how things are different in healthcare and accessibility in different countries. So we'd love to have you part of this conversation about vaccines and COVID if you're willing to let us know how things are going over there across the pond.
And Evusheld is available in Europe now. So our European people, Stephanie, you do have it available there.
That's wonderful. We've got someone joining us from Myrtle Beach, South Carolina. Thank you, Mari, for sharing this on your Facebook pages. Please, everyone, the more you care, the more you share, the more other people are aware. So please make sure that you share this post and all of Dr. Thomas's posts too on your personal Facebook pages so we can get accurate and reliable information out there. We got Canada here too. Hello, Lori. So happy to have you joining from Vancouver, Canada.
Beautiful city.
Okay, here's a great question from Robin, who is also in Chicago. Why can't you get the shingles vaccine if you are steroid dependent?
Yeah, actually, Robin, you can get the shingles vaccine. First thing I'll say is that there's two different shingles vaccine. And so one of them is, you're probably talking more about the other one called Zostavax. Zostavax is what we call a live attenuated viral vaccine. In other words, it's actually live virus that's been dummied down to where it has much less likelihood of infecting people. And so people who are on immunosuppressants should not get Zostavax. But you can absolutely get the Shingrix. Also, Shingrix is much better than Zostavax. Shingrix is not a live vaccine, so everyone on an immunosuppressant medication can get it. It's also 95% effective against the Zostavax. Zostavax was only 65% effective and wears off over time. Shingrix, you get it once and then you get a booster shot 2 to 6 months later. The only reason that we would tell someone not to get it is if they're on high doses of prednisone all the time at 20 milligrams a day or higher, or if they're having severe active lupus, and we always try to give it when people are less active with their lupus. But yes, you absolutely can get it because the vast majority of our patients were able to get them below 20 milligrams a day of prednisone. So thanks for asking, and get that Shingrix. And by the way, it was FDA approved on August the 2nd last year for everyone over the age of 18 years old who's on an immunosuppressant. So that's the vast majority of our people watching right now.
Absolutely. And you bring up a really good point. Maybe we should pause and just address this for a moment. Live vaccines. There used to be some muddy conversation about the flu vax and the nose spray that contained a live vaccine. and how lupus patients should stay away. And I think a lot of that led into lupus patients being nervous about getting flu vaccines. But can we clarify a little bit about debunking the myths about the flu vaccine and why live vaccines may be not as beneficial for people who have lupus?
Sure. So the flu vaccines that you get with the shot in the arm, those are not live vaccines. They'll never, ever, 100% ever give you the flu. We give them in the fall, at which time colds are very prevalent. So it's not uncommon for someone to get sick with the cold after getting their flu vaccine and then think they got the flu from the flu vaccine, but that's never ever happened in the history of mankind. Now, as far as also if you have an egg allergy, that's not a contraindication to getting vaccines anymore. So I'd like to throw that out there. As far as live vaccines, we don't have a whole lot of them. There's Zostavax, which is for shingles. There's the nasal spray for flu. There's the MMR, which is for measles and mumps and rubella. And there's yellow fever and some ones that we don't give very often. So those are the ones we recommend not giving to people who are immunosuppressed. However, Kelly, that's theoretical, by the way, because the studies so far that have used live vaccines in immunosuppressed patients so far really don't show them getting infected with that particular vaccine. In fact, the evidence is becoming more and more clear that they're relaxing those guidelines. And just for example, pediatric patients who are on TNF inhibitors like Humira, they can actually get the MMR vaccine now. They've made that they made that statement. People who got Zostavax, they can actually be on methotrexate, azathioprine, low-dose prednisone, because we're just not seeing those problems from it. So those recommendations will probably continue to change over time, I suspect, but we have less and less live vaccines over time as well.
Yeah. Well, that's so good to hear about children being able to still receive the MMR vaccine when they are under treatment for a rheumatic disease with immunosuppressant or have active lupus. The other question too that kind of came to mind was, there's a fear of having some sort of anaphylactic response to, let's go back just COVID vaccine, for example. I know you and I both share a common allergy to, and we can experience anaphylaxis with that allergy. And so, did you have any response to your COVID vaccine?
No, not at all. And people who have, of course, people who have multiple bad allergies do have an increased risk of allergies to other things. So there's always been that fear with the COVID vaccines, and people have had anaphylaxis. But they did a nice study, I believe it was at Harvard, where they looked at a large group of patients who had a history of anaphylaxis, anaphylactic reactions to different agents, and they really did not see an increased risk of anaphylaxis to COVID-19 vaccines. I had no problems whatsoever. I get severe anaphylaxis to crustacean or crabs and shellfish and such, but I had no problems at all, and we're not really seeing that problem.
Yes, I have the same reaction as well to our little shell friends, and
we're cheap dates, huh?
Yeah, absolutely. Bring on the chicken. I'm fine. So I brought my EpiPen to every one of my shots, and no, I never had to use it, and nor did I ever really feel nervous about it because I had read the data as well, and it seemed like it was such a small risk.
I'll throw out there real quick too that after Evusheld, they do recommend we watch patients for an hour in the office just to make sure they don't get anaphylaxis. But in that large study, there was only one severe anaphylactic reaction, and it was easily treated. So we're just being extra cautious.
Absolutely. Okay, here's another great question. It's from Mari. She says, I'm 47 years old and asked my doctor, okay, so 47, asked my doctor for the shingles vaccine, but they refused because I'm not 50. My mom got shingles on her face and head. My brother-in-law got it on his leg. I know so many people who have gone through shingles. Is there an apprehension to vaccinate before the age of 50?
Yeah, so lupus spoonies, if you're on an immunosuppressant, I would have to argue against your doctor, but not everyone might not realize the new FDA approval for people over the age of 18 years old who are on immunosuppressants. So I'm not sure if you are on an immunosuppressant, but if you are, then it is FDA approved for you, and you can get it from your local pharmacy, and just all you have to do is just tell them that you're on methotrexate or azathioprine or so forth. Now, if you're not on an immunosuppressant, if you have systemic lupus and you're just on hydroxychloroquine, then if you go strictly by the guidelines, then that is true that that from an FDA approval standpoint, you should wait till you're 50. But we rheumatologists are the kings of going against doing things off-label, because we've done off-label stuff for decades because we've just had to, because our diseases are just not studied well enough to do otherwise. But when you look at that data about systemic lupus and lupus patients being at such high risk of shingles, even if they're not on immunosuppressants, I had no qualms whatsoever about going off-label and offering it to my patients less than the age of 50. I work very closely with the Lupus Center at the National Institutes of Health, and if I send a lot of my patients there for their lupus cohort study, and they actually give my patients their Shingrix shot if I ask them to, even if they're not on an immunosuppressant. So there are some doctor variations in opinions out there. Myself and other lupus experts leaning more towards being conservative and protecting our patients.
I hope that you find that helpful, Mari. Let's see here. Oh, we've got someone joining from Australia too. We are quite international today.
Love your dog.
I've had shingles. This is Kathy speaking. I've had shingles twice years ago. Terrible. Tuesday, I'm getting my second shingles shot.
Thank goodness. I'm so glad to hear that, Kathy.
Robin's here. Hi, Warriors. Okay, let's see. Shelley, Pfizer put out a list of side effects from their COVID shot. One of them was you could get SLE. I don't need extra lupus, is what she's saying. Now, I haven't heard that. I don't know if there's anything you could do to clarify that at all.
Yes, so that all has to do with how quote-unquote side effects are listed by drug companies. They have to list what the FDA requires them to list. And so let me just explain. For one thing, it's really not seen that the COVID vaccines actually cause lupus in the first place. When we look at large vaccination studies, all the vaccine studies show no association with causing lupus. However, that's not 100% like that, because we know that lupus occurs in people who are genetically predisposed, then something triggers it to turn on. And in my own clinic, in my 30 years of taking care of patients, I have 2 patients where I'm convinced a vaccine caused it, but that's incredibly rare. You ask any lupus expert, and they can probably only list 1 or 2 people. We talk about this thing all the time. But the way that studies are done is that, for example, when you get the Pfizer COVID vaccine, they give you the vaccine, then they have you come in every week or 2 after that. Then they give you this very long list of symptoms, like it's over 100 symptoms long. Like, have you had a stuffy nose? Have you had a cough? Have you had any aches or pains, and so forth? And then if any of those are answered yes, and if they occur more than over such a percentage, then it's listed as a side effect of the medicine. For example, with almost every rheumatoid arthritis medicine, joint pain is a quote unquote side effect, but but these patients have rheumatoid arthritis, of course. The FDA is not into proving whether something causes a side effect or not, is as a potential side effect. And so, if someone develops lupus after any type of medication in any large study, then it has to be listed as a possible side effect. But when you're looking at a huge number of people who are followed for this amount of time, there are people who are going to get lupus. And the question is, did that really cause the lupus or not? It's not proven. I think that rarely vaccines absolutely can do it, but I would definitely not think of it as a definite side effect of the Pfizer vaccine.
Or maybe just the stress of reading the potential side effects caused the lupus.
Yeah. And also even...
I'm teasing, but in all seriousness, it's, you just can't tell.
And even with causing flares in lupus, and, vaccines probably do cause flares in some people. It's a very small amount in mine and others' experience. But the problem with the COVID vaccines is that we actually expect people to develop fevers and joint pain and muscle pain and other side effects. And how do you tell the difference between that and a lupus flare? That's very, very difficult. And it's very not uncommon for people to say they're having a lupus flare after a COVID vaccine when that's actually what we expect after the COVID vaccine. So we have to be very careful in how we interpret this data.
Absolutely. So Robin's asking about antibodies. Can we talk about antibodies dropping even with the vaccination and boosters?
Yes, and that's Robin. That kind of goes along with what I was talking about with different parts of the immune system being activated with vaccines. And there's actually been a lot written about this in the literature, not just about COVID-19 vaccines, but also with the pneumococcal vaccines and influenza vaccines. Is that even though we might see the antibodies decline, and that's actually one of the reasons why we're recommending that our patients get more boosters than the general population, it doesn't necessarily mean that coincides exactly with the increased risk of death or hospitalizations from COVID-19, because still the T cells and other parts of the immune system have been boosted by the vaccines, and we just don't have a way to measure those as easily as we do measuring those antibodies. The antibody levels only tell us what the B cells are doing, but not the rest of it. And even though we're seeing those declining numbers in antibodies, by the way, these boosters are greatly effective against decreasing the number of intensive care unit admissions and deaths.
And it goes back to talking about both types of the immune system, like you started the conversation with as well. Really fascinating. Mari's wondering if HPV is common with lupus patients, going back to our earlier conversation.
Yeah, sure. And just one other thing on the previous question is I always tell people some protection is always better than no protection. So even though if you're getting decreasing help a long time after the vaccine, you're still much better off than someone who's never been vaccinated. So yeah, and you're correct, Lupus Spoonies, that HPV is common among lupus patients. And as I mentioned, there have been several large studies where they looked at newly diagnosed lupus patients, and they have a much higher rate of HPV infection at the time of diagnosis. So even before being on any immunosuppressants, and we do believe it has to do with the abnormal immune system of lupus patients. And by the way, that happens way before people become symptomatic with lupus. And lupus starts off with a genetically predisposed person. They have a trigger that starts the immune system to slowly become active. And that's when the immune system is abnormal, even way before the person feels badly. And we think that that's the time period of when they're probably getting these infections like HPV infection. And then unfortunately, they have an increased risk of cancer because of that.
Wow. Really interesting. Someone is saying, I love learning from Dr. Thomas. He's so intelligent and caring.
You just made my day too. Can you tell my family that?
Now that we have just a couple minutes here, I'm just kind of scrolling through the comments. A lot of appreciation posts, Dr. Thomas, for your time and for sharing the information. Let's see, one person said, this is very helpful, especially in how we still need to protect ourselves being in public and around people. I'm always questioning if I'm being overly protective, but this confirms I am not. Thank you so very much for all this wonderful information.
As my spouse likes to say, it's not the people who are overprotecting themselves that are the problem. It's the people who are underprotecting themselves and not preventing people like you from getting infected. So thank you for doing that.
Yes, absolutely, yes. Okay, here's a good question. Do you need to withhold medications such as methotrexate and Cellsapt with Evusheld?
Cheryl, thanks for asking that. I should have mentioned that. So thank you so much. So you do not have to stop any medicines. In fact, don't stop any medicines. The difference between this and vaccines is when we give you the vaccine, we're asking your immune system to work. And taking methotrexate and CellCept keep your immune system from working and make it hard for it to respond to the vaccine. But Evusheld, you don't have to have any immune system. You can be the boy in the bubble, and you'll have just as much protection with that. You'll get as many monoclonal antibodies from that Evusheld compared to someone who is not on any immunosuppressants. So don't stop your medicines for Evusheld, and thanks for asking.
That's a great question and a wonderful response. Wow, that's hopeful, and that's wonderful to know too. And another thing too that seems to be, and I know this happened to me too, Dr. T, when a patient with systemic lupus is confirmed to be COVID-19 positive, you kind of, for lack of a better word, you kind of have a moment of panic. You don't know, okay, what am I supposed to do now with all these medicines I'm on? And you hear stop everything, and then you hear don't stop anything else. So you try and get a hold of your team of doctors right away. But there's this panic trying to make sure you're doing the right thing at the right time, particularly if you're going to get the Paxlovid, which I know we really didn't go into today, because you only have a small window to get on that antiviral if you've been confirmed infected and how long you've had your symptoms. So can you just kind of give a general overview of what you would suggest your patients to do?
Yes, as soon as you know that you're infected with COVID-19, you're exactly right, Kelly. You want to contact, and I would recommend contacting all your doctors right away, because some of them may not be comfortable with treating COVID-19. Some may not know how to treat it. It's complicated. I mean, you guys panic when you get COVID-19. We have anxiety as doctors because it's so hard to keep up on everything. The science is just constantly changing and evolving over time. So you give the best advice is to contact all your doctors. The faster you get on Paxlovid, the better. You want to be on it within the first 5 days. The faster you get on it, the more effective it is. So if you can get on day number 1 or 2, that's even a lot better. With that, if you get sick, like with shortness of breath, chest pain, and if you just have any question whatsoever whether you should go to the ER, go to the ER, because you don't want to get too sick while you're at home. And then plus they can give you more effective therapies sooner than later.
Mm-hmm. And they will run down too about what medications need to be temporarily adjusted as well. My rheumatologist did.
Oh, yes. And Paxlovid, by the way, has a lot of drug interactions. So
Mm-hmm.
if you're on medications like calcium channel blockers, diltiazem, verapamil, there's a long list of them. A lot of them have to be either stopped or decreased in dosage. And so that's a tough one because I don't even know all this. I have to look up the interactions every time I prescribe Paxlovid. But you do need to double check with your doctors to double check all your medicines and look them up on whether they need to be adjusted or not.
Mm-hmm. And there's 2 different dosing, something I learned, for those who have renal impairment and those who do not too. So a lot of us lupus patients who have lupus nephritis and higher levels of kidney disease have to be aware of that too.
Oh, and that's a good point, Kelly. Another good thing to ask your doctor preemptively is if they say they're going to send in Paxlovid, ask them to put on the prescription when your symptoms started and what your kidney function is.
Mm-hmm.
Because if they don't have those 2 things on the prescription, it can hold up your getting the prescription, because then the pharmacist always has to track down your doctor to get that information. So keep that in mind. Write that down. Please put down when my symptoms first started and put down my kidney function.
Yes, all those things really will save you time, and time is of the essence when you have a positive COVID-19 test and you're symptomatic, for sure. Okay, well, I know we have a ton of questions here that we didn't get to, but I want to be respectful of your time. It's your weekend, and maybe we can put some of these into Ask Dr. T for future posts to follow up with this live. I'm so incredibly thankful for your knowledge, your expertise, and for taking the time to share with us these insights that really just help us as a patient community increase our health literacy, debunk the fear of the unknown, and move forward with the compliance of our doctor's recommendations. So once again, Dr. T, so incredibly thankful for you and everything. And any updates on the book before we let you go here?
Yes, it's actually being evaluated for production right now at Johns Hopkins Press. I'm really excited about it because we have lupus experts from all over the world in charge of each chapter of the book. So this book's even going to be even better and more accurate than the last one. Hopefully spring will be the release date.
You hear that now, everyone. Spring. What a great gift to have to get that second edition in our hands. And as always, you can check out Dr. T on his Facebook page or his blog at www.lupusencyclopedia.com. And any other last bits that you'd like to share with us today?
Yes, knowledge is power. And so keep empowering yourself because it's much more complicated than just taking the pills you're prescribed. So you guys are wonderful taking time away to watch this today and empowering yourself to do well. So that makes me feel good.
Well, thank you. It makes us feel good too. We always love having you. You're right. Fortune favors the prepared mind is what I always say. So thanks again, guys. And this will be available on YouTube. So if you know somebody who does not have Facebook, you can share the YouTube clip or download with them. And please, if you haven't done so already, share this on your personal Facebook page so that other people can get their hands on this crucial information. Thanks for joining our spotlight on immunizations, and we look forward to having you again very soon with other updates and resources provided by More Bad Lupus. Thanks
All right.
again.
Bye, Kelly, and bye, everybody.
Bye.